I remember as a child, our grandfather lived with us. And I remember the moment he had a stroke at home. And my mother was like, what happened? We called ambulances, and my brother and I were trying to help. And then went to visit him in the hospital and involved in care and other family events. That really drew me into medicine. I didn't realize it at the time, but looking back on it, I think seeing my mother as a caregiver and how healthcare impacted our family, I just knew I wanted to do something impactful.
Hello, everyone, and thank you for listening to another episode of our podcast. Today, I'm speaking with Dr. Maria Carney, Chief Medical Director of Northwell Health. Maria is a distinguished internist, geriatrician, and palliative care physician. She has extensive experience in clinical practice, research, and public health leadership. She's also a professor of medicine at Hofstra University and is hugely passionate about caring for older adults and vulnerable populations. Maria, thanks so much for chatting with me today. Before we get deep into the interview, could you tell us a bit more about yourself?
Sure. Thank you very much for having me, Ohad. Happy to be here. As you said, I'm chief of the Division of Geriatrics and Palliative Medicine at Northwell Health. And my journey really dates back to an interest in biology, in longevity, wanting to go to medical school, never sure if I could go to medical school, but I did. And I was a resident. I had this case. I think most physicians have this moment in their training where it kind of directs their passion. And I remember an older adult male from a skilled nursing facility, and I had to put a nasogastric tube in the middle of the night on call. And I felt like I wasn't really helping him. I was maybe hurting him. And I kind of said, I think we have to do better here. We have to help patients who can't advocate for themselves. And that led me down my journey to go to into geriatrics. It was population minded. The demographics were increasing. It was complex medical care. And so that's kind of how I went. And then later on, I had other aha moments that kind of changed my journey.
Yeah, well, let's maybe start in the beginning. So I know your family is originally from Cuba. You were born in the U.S.
Yes.
And I think bounced around a little bit between different states. What first drove you into medicine?
I remember as a child, our grandfather lived with us. And I remember the moment he had a stroke at home. And my mother was like, what happened? We called ambulances, and my brother and I were trying to help. And then went to visit him in the hospital and involved in care and other family events. That really drew me into medicine. I didn't realize it at the time, but looking back on it, I think seeing my mother as a caregiver and how healthcare impacted our family, I just knew I wanted to do something impactful. I wanted to make a difference in people's lives in some way. And I liked biology, as I mentioned, and did pretty well in school with that. So that was really, I think, caring for people and caregivers and healthcare and the science, that all led me into medicine.
I'm always so intrigued to hear people's decisions on what drove them into healthcare, because you and I know, and my whole career has also been in healthcare on the tech side, but nonetheless in healthcare, this is a tough industry. And so it's always interesting, the personal why, and often it's a story like that as a kid, maybe being exposed to it. And I want to clue in on something you said, because a lot of people in your chair are talking about, I wanted to help patients, but you also said, I wanted to help caregivers. That's really interesting. So that's been kind of part of your journey as a doctor. Is that what led you ultimately to take on administration roles, is you wanted to help the people who were delivering the care?
So when I was my first job as an attending. I left New York City. I trained at Cornell for internal medicine and then Mount Sinai for geriatrics. And then my husband and I moved out to Long Island. And my first job was in another health system here. And I found myself just doing all this clinical work, just clinical. And I wanted to stop and think. And then it was 9/11 that happened. And my husband had evacuated. My husband's not in medicine. He evacuated from the New York Stock Exchange building, which was next door to the World Trade Center. And he survived, no problems. He came home with debris all over him. And I just felt very grateful that that my family was intact. And I made this kind of like promise, all right, I want to do good. I will try to do good. Kind of such a moment of gratitude. And then this notice over the next weeks to months came to our home. If you're able to help with public health emergencies, please contact. And we lived in this village that was asking for that. So I said, okay, I'm going to give back and help with public health emergencies. I went to local meetings of my town. And then I realized I had this voice being a geriatrician because everybody was thinking of emergency response plans for you and I, right, who are capable. Nobody was thinking about this invisible population of perhaps older adults living at home with no network of support, people with disabilities. So I then became academically interested in emergency response for vulnerable populations. And that was yet another aha moment where I had a voice, I had impact, and I got approached to throw my name in the hat for Commissioner of Health of Nassau County because I was working with the Medical Reserve Corps, our local town. So I began this interview process. So that became an academic interest, and that led me down a public health, population health way. And that's really where I just embrace the administrative support. That's where I embrace the administrative track.
It's interesting how you span clinical, so starting out, and giving frontline care, and then have kind of this awakening of, say, I can give more in administration, which is not an easy divide to conquer or to overcome, right? Because I think a lot of clinicians feel, wow, I've got to deal with like all this admin crap. I just want to care for patients. But the reality is that you can have a bigger impact. And it sounds like that's been part of your journey. And then you've also added an academic element to that and became a professor and kind of researching this field also academically. So you kind of this Renaissance woman encompassing all three of these aspects of being a doctor into one.
Yes, it wasn't necessarily planned. I did not have a blueprint of a pathway. I was on my journey, led with my interest and passion, and made decisions as opportunities presented themselves. And I was fortunate enough that I had a support system at home and my children were healthy that I could take these risks in trying this new path and journey. And it's so leading with my interest and passion has helped me personally.
I think that's great advice for all of our listeners, right? And many people, think about their career path. And as you and I discussed before we went on camera, it's often not a linear career path that's made by a series of well-planned out decisions. But it sounds like you've been able to stay true to that. Maybe the decisions weren't planned, but you had this kind of governing theme of like, my passion is there and it's driving me towards where I need to be. And that's kind of ultimately drove you to a kind of a higher calling versus a doctor, administrator, and as a professor.
Yes. And I think I've come to trust that if somebody feels like I'm capable of an opportunity, that I should at least investigate it, give it a chance, and then make a decision. Don't shut the door on an opportunity that someone thinks you may be able to do that maybe you never thought of. So that's what I've tried to do.
Keep an open mind, and maybe some external force helps to shape where you go next.
Yeah.
Let's maybe double click then on palliative care and your journey as a geriatrician. You talked about kind of the seminal event of this patient that you kind of were wondering, are we helping or hurting? Maybe expand on that. Like, what is geriatric care? What is this domain? Yeah. Help us understand that.
Yes, geriatric medicine is a fellowship, a specialty after a residency. And it's specialty care that focuses on older adults and geriatric syndromes. And I like to think of it in a simple way as I I learned to promote longevity, but not at the expense of quality of life. And it's person-centered care, and it's understanding also health policy, Medicare, Medicaid, payment models. In your fellowship of geriatric medicine, you're learning about models of care that are focused on caring for older adults, and that could be primary care, PACE programs, GRACE models, skilled nursing facilities, hospice, house calls, and you have rotations in all these models of care and how to show your value and outcomes. So it's more than just caring for older adults. It's really about how a health system should care for older adults. And I don't think people realize that geriatric medicine training encompasses all of that. And then out of geriatric medicine comes palliative medicine. There's a component of palliative medicine in geriatric medicine, but there's also a separate specialty of palliative medicine, which really focuses on, came out of the hospice movement, but it's really trying to help symptoms and quality of life as people face serious illness.
And so, big picture, a lot is talked about the fact that our population is aging. We're all living longer, maybe also having less kids than perhaps a generation back. We are becoming more and more independent in our elder years. And I think are less maybe conformant to this model of like kind of getting shipped into a care home as you get older, right? There are more financial independence, more physical independence. How is all that shaping geriatric medicine? All of these demographic shifts?
As you said, the population is aging, meaning we are living longer. And the data is that 10,000 individuals are becoming 65 and older every day. The baby boomers are entering this new demographic. Our life expectancies have nearly doubled in 100 years, largely to public health issues, clean water, injury prevention. But now we're in a whole new aspect of medical care, from vaccinations, antibiotics, joint replacements. Now we have transplant medicine. So we can treat so many things so differently. Chemotherapies that didn't exist years ago. So the population is aging. Yes. Our treatments are expanding. Yes. We are living longer. However, the healthcare system hasn't really changed much in this time period. We have the same number of beds or less in hospitals. Our home care resources and community resources are shrinking, or does it in relation to the need is less. And we have a real problem in society. But the good news is, because we're living longer, right, we're going to be productive for a longer period of time. Mm-hmm. We can be influential in so many ways, but we still have to prepare for when we may have times of need.
Yeah, and I think your point around really preparing the healthcare system, and for example, for me as a technologist, thinking about what that means from a technology perspective is fascinating. I read some stat, I'm sure I'm butchering it, but I want to say that the kind of over 65 population maybe reflects about 20% of the US population, and it consumes about 40% of all expense. Something to that effect. I'm sure, again, I'm getting it wrong, but generally the trend is right as you live longer, but also you have broader, more complicated care and more kind of comorbidities that the system has to deal with for a longer period of time now.
Yeah. Our healthcare system is built on dealing with diseases, right? We have heart hospitals, we have cancer centers, but as we live longer, we accumulate multiple chronic conditions, which in general, we manage for a long time until there's a point where it becomes tricky, right? Where you start having to treat one thing, but it impacts another illness. So I spent a year doing a fellowship in health policy, and I was assigned to the Centers of Medicare and Medicaid. And the number one chronic disease is having multiple chronic diseases.
That's a bit of a tautology.
Yeah, it is. And we don't necessarily know how to treat someone with multiple chronic diseases who may have functional impairment or cognitive impairment because they're really not part of any studies. So that is where we have to move to either person-centered care, shared decision-making, or deliver care at home when they're having difficulties because it's harder to access care. And it's very hard to do all this specialty care when you're having a difficult time.
Yeah, maybe let's unpack that last point, Maria, around care at home. It's an area that I'm fascinated by because I think, we're a handheld ultrasound company. Our mission is to enable access to care in many new settings. And really the promise of handheld ultrasound is that, right? Because we're not going to replace legacy carts in the basement of radiology and cardiology where they're well entrenched, they have a sonographer, and the system works. The promise of our technology is about bringing it to a practitioner that maybe never thought they could use ultrasound in a care setting where you couldn't have previously had access to it because it wasn't portable or it was too big or too expensive or not wireless or whatever the case is. And so I'm really interested about kind of movements and specialty areas that are driving the care away from the hub and into the spoke, which also going back to your point around like we have less resources, less clinicians than we did before. We have to find new ways to deliver care. It can't all be predicated on this kind of hospital-centered, physician-centered model. So how does kind of that movement of decentralizing care fit into where geriatric medicine is going?
So I want to go back to your point about the 65 and older population is about 20% of the population utilizing 50% of healthcare. Mm-hmm. You're correct in that, except that it's really the top 5% of that demographic is utilizing 50%. So it's the greatest time of need. And what we see is as we have multiple chronic conditions to the point where it starts affecting our ability to function or cognitive, and you have difficulty caring for yourself. That's the stage where we really need to focus our efforts. It is that population that's having trouble going to their primary care physician or going to their cardiologist because they're dependent on a caregiver. It's not easy to go. So it's that 5%. And we write about it in our book. There's some great people that we interviewed for our book. Michael Dowling, Charles Kenny, and I interviewed for The Aging Revolution that developed house calls, home health care. Eric DeJong is one of them. Bruce Leff is another one. Christine Ritchie, another one, talking about this network. But we need to help that population who is using the emergency department as their primary care because they can't get to doctor's offices. We've got to reinvent how do we help them the most because they don't want to go to the emergency room. They don't want to be in hospitals. They really want to stay home. So that's where we need to focus. It's not.
And then the point about cost is if we were able to care for them in the community, as opposed to consuming the most expensive resource, a hospital bed, an ER bed, that would actually decrease the proportion of cost that's tied now to caring for this 20% of the overall population.
Yes. And we have to also reinvent primary care because primary care, the way it's been set up now, is not able to care for people with complex needs. And this is why I love geriatric medicine. It's complex. You have multiple problems. You're trying to help a patient. It's psychosocial. You create care models. And that gives me, it's not boring medicine. It is complex medicine. So if we can, we're spending the money, right? Emergency departments, ambulances, back and forth. If we can target to minimize that, then we can save those costs and just redirect those costs.
But I want to come back to a point you talked about reimbursement, because it strikes me that part of this movement of decentralization and moving from kind of sick care to healthcare involves prevention, involves kind of early engagement, which in a fee-for-service, principally, we're still in a fee-for-service model.
Yes.
That's kind of counterintuitive, right? So how do we overcome that? How do we incentivize primary care doctors? And I'll tell you, I see this all the time in our world. We don't sell actually that much to primary care. We sell mostly to specialists. Why? Primary care docs say, listen, I've only got 8 to 10 minutes with a patient. Yeah. I talk to them about something for 7 minutes. It's kind of incredulous to say, Maria, I see we've got another 90 seconds. Why don't you lie down on the bed? I'll do a head-to-toe ultrasound scan, and I can see if your ejection fraction is on par, whether you're having compensation issues. And so they don't have the incentives to do that, so they don't. And they say, if something happens, just go to the ER, or otherwise I'll refer you to a cardiologist, which is also a very expensive resource, and they can see you in 6 months.
Right.
And so how do we overcome that with reimbursement? How can the financial alignment support this model you're talking about?
It's going to take a collaboration of federal policymakers, insurance companies, healthcare systems. Healthcare systems are largely still fee for service. Insurance companies want to save money or spend less, and policymakers want to make sure everybody's treated fairly. So it's going to have to take stakeholders to reinvent primary care and delivery of care at home. I will say, delivery of care at home care medicine, is being evaluated now for its own payment model. We've got to support that. We have to, and that's a policy decision. So I think everybody should be aligned, because as the population increases and healthcare treatments increases, hospitals are going to be busy enough, right? We're already seeing emergency departments overwhelmed, people in hallways. So we really have to improve care at home. And we're all united. We know how to do it. It's just we have to be united on how to do it. It sounds simpler than it is.
No, and I know that not all attempts at this have been, maybe some are gaining good traction, but not all have been as straightforward as we like. Like, I'm quite familiar with how Medicare Advantage works, which I understand the idea behind it is to say, we're going to incentivize an insurer to bear the risk for a patient, and we'll compensate them with more if that patient has more comorbidities, more complexities. Right? That's the idea behind adjustments in your Medicare Advantage fees. But on the other hand, doesn't that incentivize kind of like symptom finding, right? And like just trying to be able to pile on and say, oh, this person has this thing, now I'm being billed at a higher level. So like, how do we balance that where there's still like the financial incentives? Everyone wants to do the right thing, but maybe it's just recognizing it's complicated. Like you said, I'm not sure what the answer is.
It is complicated. I think there are insurance companies that want to do the right thing and can do the right thing, but it becomes, some of the concerns are they're over-labeling diseases, they're screening charts and giving them a more complex illness rating so that they get paid more. But how do you show that that's accurate, right? How do you show that? So maybe it should be about, if this individual used the emergency department 2 times in the last 6 months, they need more help. We're missing something. Maybe that's how we should help them, rather than just looking at charts.
The charts are driven by indications, right? Or history, you're a smoker. Did you have this type of episode or not? I understand. So you're saying, let's actually look at, not all smokers are the same, maybe. And someone has exacerbated lung conditions as a result and is going in regularly. That's a different risk profile than someone who isn't having the same symptoms, even though they may have ticked the box of being a prior smoker in their medical record.
Christine Ritchie and Bruce Leff talk about a home care network based in primary care, where you have the primary care doctor, but you create these networks to help them as they have difficulty going to the office, and you start delivering care to home, kind of that hub and spoke idea that you mentioned, and they speak to it. So it's been written about. They have evidence that it shows it helpful. And it's interesting, Eric DeJong, when we interviewed him, he's at Georgetown about home care medicine. He talks about he loves going to the home because it's more personal. You understand how they're functioning and you can deliver the care sooner. But there's prevention in these visits. You're preventing harm. You're preventing utilization of healthcare that people don't want. So there's a prevention of illness, but there's prevention of utilization of healthcare. There's prevention of across a life course. And it's not just about staying healthy. You have to prevent when you maybe are facing problems and what matters most to you. An age-friendly health system is another framework that's brought up in helping care for individuals. And I would love insurance companies to help and payment systems adopt an age-friendly framework, which is we can talk about when you're ready.
Well, that's a great call to action, I think, for the insurance companies to retool some of how they think about this and recognize that they're bearing the cost downstream, and therefore you have to find the right correlation of investments up front to prevent that downstream expense. Many of our listeners are technologists, med tech entrepreneurs, technology companies. So we've had a call to action to the payers. What about to technology. How can technology do a better job of helping health systems retool for this world where we have an aging population, we have decentralized care? What should we be thinking about as technologists and innovators?
I think technology can be helpful to improve access to care. So if someone's not feeling right, how do they get better communication to their healthcare teams? Right now, it's still old school. You call the office, you wait for a call back, but how can we improve that? Is that just through the electronic health record? Are there other systems to notify your doctor without ruining a doctor's life, right? To have some control that's quality, that's safe. So I think that's one thing. How do we improve communication and improve access with your healthcare team? The other issue is when someone's at home and they need assistance, technology has been thought of how to help them, whether they need resources, education, but you're only as good as who's on either side of that technology. So if we build technology, I want to make sure who my patient's talking to has the right information. Do they know what they're doing? Are they certified? Are they qualified? Does it help the doctor-patient relationship or does it hurt the doctor-patient relationship? So that's one side of it. And the other side of technology is, can the patient use that technology or can the caregiver use that technology? So who's on either side of the technology? And I don't know that as people are developing technology, they realize perhaps we're not assessing well the abilities of the patient, the individual, or abilities of the caregiver or availability of the caregiver to help.
That's really interesting for us. I mean, how can we do a better job of that then? Like, is it more spending time to understand the clinical workflow? What does the actual encounter look like to understand what could each side do? Could the patient understand this technology? Could they use it themselves maybe, or the caregiver? And I think even the caregiver models are changing. A lot of healthcare companies design their products for doctors. The reality is we're seeing, big proliferation of frontline care being delivered by PAs, NPs, nurses, social workers, right?
And
What are
families.
those roles? And families, yeah.
Family caregivers. We're sending people out of the hospital to the home with injections. They have catheters. They're getting infusions. And family caregivers, they need to be able to call someone and say, I don't know I need education. So the individual needs to be able to call someone and the families need to be able to call. So that's where that access to communication, access to education, access to resources. So you're only as good as who's on either side of that technology.
I would love for ultrasound to actually take the next steps. Already, like we discussed, it's kind of moving from the hospital basement to the clinic, to the office, often to home care in the hands of maybe a nurse. And ultimately, I think the next divide is actually in the hands of patients, but in a very different use model where, like you said, you can see like Holter monitors are being taken home. Why is that? Is because the AI is actually doing the analysis. It's just collecting the data at home. And then the AI is doing the analysis to help make a more informed decision for the doctor offline. I think ultrasound could get there as well, where it's not about the patient acquiring a good image. I think the FDA wouldn't want patients self-diagnosing, but rather that you're using maybe an ultrasound patch or a technology like that to collect enough signal. And then offline, you're having AI interpret that and make an informed recommendation to a clinician. So
Interesting.
FDA still has not approved ultrasound for use by a patient, but actually we have a few clinical trials that we're involved with and other companies in obstetrics for women to monitor their fetuses at home and also in fertility. And that space is coming up. And so, yeah, maybe geriatric care is another one. You could envision instead of stepping on an electronic scale to know whether you've retained fluid for COPD, of having an ultrasound measure the interstitial lung fluid and, help the GP make an informed choice on whether they have to change the titration.
Yes. Fascinating how this world is changing. But also, we also have to remember, what matters most to an individual. Because, you can have very complex medical situation and you can treat diseases many different ways. But what matters most? Maybe a person doesn't feel so well when their sugars are so tightly controlled and they prefer to lighten up. Or, I've seen with patients with congestive heart failure on a diuretic, they're given a regimen that helps their congestive heart failure, but they often will not take it on a certain day because they want to go to lunch with somebody and they don't, so you have to kind of balance the pragmatic aspect of healthcare and what matters most to a person versus managing a disease perfectly.
That's such an important lesson for us, and on the technology side, right? Is again, we focus on the disease, the clinical condition, and you're doing a very good job reminding us there's a patient here that has preferences and is maybe imperfect in adhering to a plan and has other needs that aren't just managing that specific condition. So that's invaluable. We've discussed a little bit of the payer landscape. We've discussed some of the technology landscape. Tell me a little bit about maybe the provider. Like, what's your call to action to providers? How can health systems that maybe don't have the scope and the scale and the sophistication of a Northwell yet help to build this out as an important part of their operation? And how can they kind of forge ahead and make geriatric medicine a bigger part of what they focus on?
Yeah, I believe health systems really have to embrace the age-friendly health system initiative, which is put forth through the Institute of Healthcare Improvement, IHI, and sponsored by the John A. Hartford Foundation. And it lays out a 4M framework, evaluating for mentation. And we need to screen for cognitive issues and mood issues, behavioral health issues, medications, understanding medications and what medications are harmful as we get older because of kidney, liver issues and risk of falling, mobility, how to live independently more safely over time. We need to focus on that. So, and then what matters most, which we talked about. So I think technology can play a role here, thinking of that 4M framework, right? How do we help individuals with cognitive impairment or behavioral health issues? How do we help managing medications or preventing harm from medications? A lot of people are taking a lot of medicines, they have no idea. So there's a role to help that. Mobility, being safe. You want people to live independently for as long as possible, and what matters most. So technology also, as we are dealing with this growing population with complex medical issues, which is wonderful. We can help people live longer while dealing with medical problems, but we need to keep in mind that 4M framework.
Well, we're going to start to wrap up our conversation. Gotten a lot out of this today, and I know that our audience probably wants to learn more about what you're talking about. I certainly didn't have the exposure to kind of the depth of thought behind geriatric medicine and where it's going. You mentioned a book, Maria, that you published. You want to tell us a little bit about that?
It's called The Aging Revolution. And if you see Michael Dowling, lead author, he's the CEO of Northwell. But we really feel that we are at a critical time in healthcare and society, how to help people and not have healthcare contribute to harm. We really need to reinvent healthcare systems. And we talk about that in the book in several chapters, from delivering more care at the home, identifying caregivers and really helping them provide care, age-friendly health systems. We also look at the rise of palliative medicine in society and how it came and why it came to rise. And then it starts talking just what you brought up, Medicare Advantage. There are changes in Medicare that are happening right before our eyes that a lot of people don't understand. And a lot more we have to learn to make sure we help our older adults in getting the right care at the right time and at the right place. So, and then lastly, I think the focus of this book is where I think we as a healthcare system in Northwell are trying to make changes, delivering more care at home, trying to see if we can reinvent primary care and identify and help caregivers in their role because they're an unknown part of healthcare delivery.
That's The Aging Revolution. I will definitely pick it up. Maria, if our audience wants to follow you or get in touch with you, how can they best do that? Through social media, or where can they find you?
Yeah, I'm on X, formerly known as Twitter, at mcarneymd, and I'm on LinkedIn, and at Northwell Health, you can look me up. I'm very available. I really appreciate your interest and time. I've enjoyed this so much.
Me too. I learned a lot today. I'm sure our audience has. Thank you so much for spending the time with us today. And to our audience, thank you for joining us for another episode of our podcast. That's a wrap. Bye-bye.